many things that can be done, but I'd also argue that there are many things that we don't know yet. In particular, again, because the share of healthcare costs with which there is evidence associated is so small, the challenge in moving towards creating incentives towards higher value healthcare is significant, because in many cases we just don't know what works and what doesn't. So that was the main theme of my testimony. I also covered a variety of other topics ranging from employer-sponsored insurance to uninsurance to the importance of prevention and healthy living. I'm not sure if you want me to cover those topics now or move right to questions, because I know that I have spent a significant amount of time just going over that most important topic, Mr. Chairman.
Now, I think, why don't we go to questions, because we've got members here who are very interested in pursuing their questions. Let me ask you this question. 30%, I just did sort of a back-of-the-envelope calculation. You'd indicated in your testimony we could save 30% of health care costs if we just had best practices replicated throughout the country.
Let me just really quickly note that is a Dartmouth estimate. It's not a CBO estimate, but it is an outside estimate that exists.
Okay. And it's a pretty credible estimate, given the people at Dartmouth who did the analysis. I've met with them. They're
credible researchers.
They're credible. They're serious people. 30%. We've got to be spending over $2 trillion a year on health care.
That's correct.
So 30% savings would be in the range of $600 billion a year. If we were able to have the practices that are already pursued in very large parts of the country. I mean, geographically speaking, as I looked at your map, roughly half of the country has the practices in place that would lead to that kind of savings if they were broadly distributed. Is that?
A significant part of the country, there's a question about how you do a lot of those states are smaller states, so there's a question about the population weighting. But the point holds, which is that there are significant parts of the country, in fact, the four of you right there represent parts of it, where costs are much lower than other parts of the country and where quality is not any worse.
And how have you thought through how we could spread those practices? How could we effectively get those practices adopted in other parts of the country?
Well, I think it will likely require two things. One is I think it does require more information about exactly what works and what doesn't for specific interventions, you know, coming back to the should you do an MRI after your hip fracture surgery or not kind of thing. And then it will likely also require changes in incentives for providers so that they would be presented with incentives to pursue value care, high value care, rather than just churning high cost care.
Let me go to another subject that has captured my attention, and that is roughly 5% of Medicare beneficiaries, 5 or 6%, use half of the money.
Yes.
They're the chronically ill.
We have a chart that we could pull up on it.
Yeah.
So I think that's figure 5 or 6. Keep going. There you go. So the top 5% in 2001 accounted for 43% of costs.
5%, and if we go to 6%, they're at about 50% of the cost.
Are they terminal?
Well, they're people that have multiple serious conditions. They are, we know their care is not well coordinated. There was a study done with some 20,000 of them in which we put a coordinator on each one of their cases, and a dramatically lowered cost. In fact, it lowered hospitalization, as I recall, more than 40%. Just to put case managers on each one of their cases, because the left hand doesn't know what the right hand is doing. Have you examined this phenomenon, and can you tell us, is there a potential for savings there? And interestingly enough, in the study that was done, not only did you have significant savings, you had better health care outcomes.
Yes, Senator. This is obviously, just looking at the data, healthcare costs are very concentrated. It makes sense to look where the money is, and there is potential for cost reductions through better interventions for those types of beneficiaries. I would note, though, that the data to date is somewhat frustrating in the sense that it does not suggest strong evidence of overall cost savings from things like care coordination and disease management. Medicare is currently doing a variety of pilot projects, including a randomized experiment on precisely this topic. The early evidence suggests that quality may be improved, but the net effect is not a cost saving. And it may well be that part of the problem is that it's very hard to target the right interventions to the right subsets of the population that would most benefit from it. Potentially with improved electronic health records and improved health information technology, that targeting may occur in a better way. In the absence of that, the problem is that you're providing a service to a broad array of people that costs money, and if it doesn't work for for a significant share, you don't wind up saving money.
Let me just say, in the study I was referencing, the first thing they did is go in and get all the prescription drugs out on the table, and they found out on average these people were taking 16 prescription drugs, and when they evaluated each one of them, they cut it in half, and that led to dramatically lower hospitalization. Perhaps you were talking about the early stages of studies that are being done now. We may find that over time the savings grow.
And if I could just add, I know that private firms are trying to move towards more sophisticated targeting and intervention, and we are actively monitoring those developments and eager for empirical evidence on what might work and what might not, because again, there's an opportunity there, and the only question is, could it be captured?
My time has expired. Senator Gray?
Thank you. I think it's important to note that it's a nationalized system which has created this inefficiency essentially in Medicare. Medicare is not, it is your classic universal coverage nationalized system. And that if you're going to generate any significant savings in health care, you've got to get, as you said in your second set of presentation, more participation by the consumer through cost and more knowledge and transparency from the purchasers, specifically the insurer and the businesses that are paying the health care costs. And if you can't get those two things into the process, you're not going to be able to drive better practices. It's very difficult to capture this represented 30% cost that is over, which is not producing better outcomes, unless you have a system which encourages the patient to be an intelligent purchaser and the insurer and the businesses that are paying for the patient, when you've disconnected that cost, to be informed purchasers. In order to accomplish that, I've introduced a bill with Senator Clinton called the Medicare Quality Enhancement Act. Are you familiar with that at all?
I am.
And the purpose of that is to get the information into a centralized place, the Medicare information and the other major provider group information, such as Kaiser Permanente statistics, so that an employer or an insurer can go to a central place and get information that's hospital-specific, doctor group-specific, on what the outcomes are and what the costs. Do you think that that would potentially help in some of this process?
Well, let me say this. I think the largest return to health information technology and electronic health records is likely not to be the internal efficiency gains that some studies have identified, but that we have some questions about, but rather that it would provide the information to allow the kinds of things that you're talking about, comparative effectiveness research, feeding information back down to providers. So it's a sort of systemic question. Just by itself, without those other kinds of analyses, it doesn't do as much as some studies have suggested.
Well, the purpose of this is to simply create a clearinghouse where people could get that information if the information was being effectively developed by Medicare, rather than having it sit in the Medicare office somewhere and having it just accessed by the small cadre of health experts who would have access to it. I don't see it as the solution, but I see it as part of the solution. You know, one element. It's a multi-pronged issue. I'm wondering also, that 5% who's using 40%, that's a public policy dilemma of considerable proportions, because a large percentage of that 5% is in long-term care and end-of-life situations. Isn't that correct?
Something like a quarter or so of Medicare costs are rising in the last, I believe, 6 months. But the point is, towards the end of life, there are very concentrated healthcare costs.
And how does a elected government deal with that issue?
Well, again, I come back to the same thing, which is for someone who's near the end of life and there are various different interventions that are possible, if it turns out that the more expensive intervention is not actually going to extend your life anymore, you may think twice about doing it, and the providers may think twice about doing it. I think even in end-of-life decisions, more information about what works and what doesn't to extend life would be very beneficial, and we don't do enough of that.
Well,
But I wouldn't.
most of those interventions, that's not, there's always an assumption that they're going to make the quality of life better for the person.
An assumption without evidence in many cases. And
Well,
this
I
is
guess
not.
my question to you is, do you have any concept as to how a government that functions on the basis of concern for the individual is going to deal with dealing with end-of-life decisions that are driving health care costs, which probably don't extend life, but may give quality of life improvements?
At some point, obviously, you reach value judgments that I'll have to, that policymakers like yourself are elected to evaluate. And
Well,
I'll leave it at that.
regrettably-
I would note two other things, though. The first is that, obviously, while end-of-life costs are important, there is a significant amount of healthcare costs that are occurring outside of that.
We all accept that, and hopefully we can get to that issue also. I believe my time's up, but thank you. The information is, I totally agree with the information you put forward and just hope that we can get some action on it.
Senator Wyden.
Thank you, Mr. Chairman, and thank you for your superb leadership on the topic and our many questions. And Senator Gregg, you say that we know what needs to be done, and yet it's not getting done. I've joined with Senator Bennett, a member of the Senate Republican leadership, on the first bipartisan health care overhaul in 15 years. So my message, Senator Gregg, is there is bipartisanship coming to a committee near you very quickly. Senator Bennett and I will be the leadoff witnesses on Tuesday for our legislation on the Healthy Americans Act, which does make it possible for all Americans, according to Lewin and Associates, sort of the gold standard of health policy analysis, to receive coverage like members of Congress do for the amount of money that is being spent today. And according to Lewin, there would be savings of $1.5 trillion over the next 10 years. But since we are going to be taking that up on Tuesday, let me get into my questions for Dr. Orszag. And Dr. Orszag, thank you again for a good piece of work. And I want to start with one of the more important policy issues that I think is going to relate to the future of American health care, and that is how we promote prevention and wellness and, in effect, get away from this sick care system. And I think this is going to be a great challenge for all of us. And essentially what we have is a situation where the private sector, companies like Safeway, that helped me extensively with my legislation, feel that they are producing very substantial savings by rewarding prevention. And you all in government, I think, look at these studies and are saying, how in the world do we score all of it? And in fact, under our legislation, we tried to be very conservative. That's what the Lewin people said, is we didn't score prevention at all. So we give authority to Medicare, for example, to reward in Part B the outpatient program, authority to reward people for lowering their blood pressure, lowering cholesterol. We don't score that. We don't score any of the private savings, for example, that the private sector is doing in prevention. What are your thoughts on how we come up with a way to make sure that the future of American health care is built around these sensible preventive practices so we can reduce the chronic care costs, Senator CONRAD correctly points out, and move forward with a very different vision of health care?
Thanks for the question, Senator. As my written testimony emphasizes, perhaps much more important than the healthcare system in determining the healthiness or health outcomes for individuals is precisely prevention and healthy living. And we have experienced over the past 2 or 3 decades a very significant increase from about a half to 2/3 of the population that's either overweight or obese. Smoking rates have come down, but they remain higher than where many medical professionals would like, and roughly half of preventative measures that are recommended are not, or half of the people who don't get the recommended preventative steps. All of that combined is a significant issue, often outside of the healthcare system per se, that will have substantial implications for the environment in which Medicare, Medicaid, and the rest of the system operate. And the reason I wanted to include that section of the testimony is I think this is critically important, and there are a whole variety of interventions that have pros and cons and that need to be evaluated carefully, but that hold the potential to improve how we live, basically. And I think there are a lot of decisions, I'll give you just a little vignette for a second, in which we're not behaving in a way that we even ourselves would want to. I know, just very briefly, there was an experiment done, I referenced in a footnote in the testimony, in which people were put in front of a movie and they were given buckets of stale popcorn. It was 3 or 4 days old, nothing anyone would ever want to eat. The people who were given larger buckets of stale popcorn ate more of it than the people who were given smaller buckets of stale popcorn. There's a lot that we're doing that is affected by our environment and by how we make decisions that affect our health.
And I won't take on the movie theaters for purposes of...
This was an experiment. That was an experiment.
I just want it clear. I want to work with you on this point because we've got a disconnect. The private sector says that they're making significant savings with preventive practices. Government has been taking an approach that I think probably we'd all say is more cautious. I'd like to work with you on that area. Let me ask about one other issue, and that's the role of the states. The states are very concerned about federal inaction on this subject. And what is so important about your testimony is you've made it clear that the consequences of inaction on health care are devastating. They are staggering, and I appreciate your spelling it out. But isn't it correct that the states cannot fix the health care challenge in this country because they can't touch the tax code, which drives conduct for 170 million people with employer-based coverage, and they can't touch Medicare, which Chairman CONRAD has correctly pointed out is the driver of entitlements. So I want to give the states a lot of credit for their good work, and they're doing imaginative, creative stuff. But isn't it correct that the states cannot fix health care because they cannot deal with the biggest drivers that I mentioned?
I would agree with you that with regard to cost and quality, which are 2 of the 3 important dimensions along which to evaluate health changes, the states are limited in their ability. They seem to be doing more on coverage, which is the 3rd component of thinking about changes to the health system.
I commend you for your good work, and Mr. Chairman, look forward to Tuesday as well.
Thank you. I look forward to Tuesday as well. You know, the ranking member threw down a challenge to let's move this to action. I couldn't agree with him more. We're going to be talking about action on Tuesday, and it's a bipartisan proposal. Senator Bennett, Senator Wyden. There will be others who have competing proposals. We're going to hear from them all because we think it is critical that we give the American people a chance to hear what the ideas are for really transforming the healthcare system in the country. We're headed for a cliff here. I don't know what could be more clear. The only way that I see that it's going to be dealt with is in a bipartisan way. Nothing can pass here unless it's got support on both sides of the aisle, and nothing can ultimately be implemented unless the President of the United States is on board. So if we are serious here, and I think the vast majority of our colleagues are, the only way it's going to happen is with some larger agreement. And that means compromise on both sides, and that's always difficult. Senator Stabenow is next. Senator Stabenow, I want to again commend for her involvement in this issue. She has been ferocious at defending Medicare and also very constructive on this committee in the various reserve funds that have been created that really would save substantial sums of money according to all outside experts if they were adopted. Senator Stabenow?
Well, thank you, Mr. Chairman, very much for your focus on this and the passion of Senator Wyden and focusing as you are working in a bipartisan way. And Senator Whitehouse, who's brought such wonderful new passion and interest in health IT as well as other areas. I'm so glad we're talking about this. Just to stress the point in terms of why this is so critical, I believe that fundamentally it's the most important thing we can do to help our businesses be competitive in a global economy, to focus on our quality of life, on the federal budget. It is singularly the most important thing that we could do with the broadest impact for the future. Just as an example, yesterday, big headlines in the Wall Street Journal, Toyota will no longer be making automobiles in the United States. When they make them in Japan, they pay the equivalent of $95 per vehicle, as opposed to here at $1,500 per vehicle.
Just for the healthcare component.
Just for healthcare. And so when you couple that with the fact that, and I will not belabor the point, but Japan is manipulating the yen, and so they get a great discount by shipping them from Japan. So that's more American jobs gone. And our folks are here trying to figure that out. So it's huge. And I want, though, to, and this is less of a question, I guess. I do have questions, many, many questions, but I would like to take us, though, to 30,000 feet on this for just a moment. And first of all, say prevention, obviously critical for the future, a focus on chronic diseases, diabetes, heart disease, the 5 chronic diseases which take up so much of the healthcare system, quality, transparency, consumer choice, all of those things are critical, all those things. But when we only focus on that, I mean, Mr. Chairman, I believe there is a fundamental question that separates us from other countries and the reason our costs are so high, that we start from a position that is fundamentally different. In every other country that you mentioned, and I have your chart, every other country, the focus and the structure is on healthcare as an essential public service. In the United States, we have a healthcare industry. When I look at Ireland, Finland, Luxembourg, United Kingdom, Japan, Italy, Austria, Netherlands, Cuba, which is in a current film, I don't think they have more information than we do about outcome. They don't have, they have better outcomes. They don't have more transparency. They don't have more information. They don't have more efforts than we do, like we're talking about now. Why are these costs fundamentally so different with other countries that aren't smarter than we are? They're not doing better quality control than we are. What is it? And my concern is that if we only focus on providers of health care, which I believe we absolutely need to be, certainly a piece of it, or consumers, and we don't focus on the fact that we have huge money being made off this system. That's the difference between these countries. And I realize that I come from, I think, a little different perspective than, certainly than many here in the Congress. But the big difference that we don't talk about is we have a round peg and a square hole, and we're putting them together here as we look at how do we structure this. And I'll give you an example. Medicare has a 2% administrative cost. Now, rather than expanding Medicare with prescription drugs within Medicare to get the savings from that administrative cost, we created a private sector model. Now, we can debate good or bad, but the truth is it added costs. Didn't take away costs. It added costs. It added administrative costs. It added layers of cost because private sector is 15 to 20%. Medicare Advantage, and I think I support having a private sector option. But that was supposed to save us money. Mr. Chairman, you've been extremely articulate in that. That was supposed to save us money. And now we are seeing that, as you indicated, even if we were to pay 50% more, 150% for the private plans versus the public plans, we would save money if we capped it. So I am very concerned that as we hone in on things, all of which I'm very supportive of. That there's like the 800-pound gorilla in the room that we're not focusing on, which is the fact that there are those who will fight change because there is huge amounts of money being made in this system. So how do we address public interest versus private interest? And I know that's a big challenge for us. And that leads me to my question. And thank you for your input. And I should also say, health IT, huge savings. There's huge things that we can do. But Medicare Advantage, CBO estimated that setting the payment for Medicare Advantage at 100%. And I'm not suggesting that we not allow a higher payment. But if you were to set it at 100% for local fee-for-service, as recommended by MedPAC, you indicated it would save $46 billion over 10 years. Now CBO is saying that the savings would be $160 billion over 10 years. It's an increase 3.5 times higher. And so I'm wondering why you're assuming the much larger overpayments and why it is getting so much larger. What's happening in that number?
What's happening is that enrollment in Medicare Advantage has grown substantially, and particularly within the private fee-for-service component of Medicare Advantage, we now anticipate rapid growth over the next decade. So the base of savings is very much larger than it was last year.
So there's more people. Basically, you're saying more people.
More
going
people
into
driving
that?
a higher level of federal subsidy for each,
Right.
right.
Right, okay. Well, Mr. Chairman, you have been patient with my time. I know I have gone over that, but as long as the chairman's sidelined here, I'm going to ask you one more question. Isn't it also true that the isn't it also true that for those overpayments that everybody else under Part B, everybody else in the public system is having higher premiums as a result of that?
Yes, it is.
Okay. Thank you very much. Thank you, Mr. Chairman.
Senator Feingold.
Thank you, Mr. Chairman, for holding this hearing today. I'd like to thank Dr. Orsach for being here. I'm pleased that the committee is focusing on health care reform today. I often point out that when I go to each of Wisconsin's 72 counties every year and I hold a town meeting in every one of the counties every year, health care is almost always the #1 topic that I hear about. It's a very important issue to me and to everyone. I commend Chairman CONRAD for responding to the importance of this issue by launching a series of hearings on health care reform, and I'm pleased to be here for the first one. There are many problems in our health care system that I think are overdue in receiving proper attention, and these issues converge with the problem of the uninsured. Health care costs are driven up, hospitals and clinics are overburdened, and communities and families struggle, all as a result of uninsurance. We've got to figure out a way to break this deadlock, and that's why I've introduced a bill with another senator on this committee, Lindsey Graham. Last month, we introduced the State-Based Health Care Reform Act, which gives certain select states the funding and authority to cover the uninsured within their state. This bill makes political sense, because it encourages initiatives we've already seen in places like Massachusetts,